Lunch. Today, my talk is titled Improving Childhood Kidney Outcomes in Premature Neonates with Kidney Oxygenation Monitoring and Caffeine. I do not have any conflicts of interest to disclose, but I will intend to discuss some unlabeled, unapproved use of drugs or devices. The objectives of today's talk are to explain the impact of premature birth on future chronic kidney disease risk, demonstrate how to measure renal oxygenation and explain normal and abnormal values in the neonatal intensive care unit, identify how caffeine use in premature neonates affects both short and long-term kidney function. And one of my other disclosures is that I'm really passionate about the kidneys, such that now even when I'm making food at home and cutting up tomatoes like this one, I see kidneys. So here I thought it was a nice representation of a kidney that might have some fibrosis or scarring. The seeds are the little glomeruli. So this was my most viral Twitter post that I've ever had. So if you'd like to follow me on Twitter, I repost a lot of kidney stuff at triplebadger.10. So I always start off my talks talking about nephrogenesis. So nephrogenesis typically begins around week 8, and there's a rapid increase in nephron growth that occurs in the 3rd trimester. So when we have a baby who's born around 35, 36 weeks, nephrogenesis is basically complete, and most babies and adults then ultimately have about 1 million nephrons. However, in our most premature babies who are born 22 to 23 weeks, they are born at a time when they have very few nephrons, and we'll talk a little bit about how many nephrons we can expect these preterm babies to gain while they're in the NICU. But a really important concept is that once you're born and after 36 weeks gestation, you don't form any new nephrons. So all of us lose about 4,500 glomeruli per year after the age of 60, and that's why we typically see chronic kidney disease later in life. Somebody normally will follow this dark line curve here, where they still have enough renal function by the time they get older, and most people don't have chronic kidney disease. But we worry about our preterm babies and other babies in the NICU with high nephrotoxic exposures who might lose or not start off with as many nephrons and then lose more nephrons rapidly and develop chronic kidney disease. Here I've listed just a few of the adult and pediatric things that can contribute to chronic kidney disease, but we also know there's a host of other factors that contribute both prenatally and in the NICU that can affect kidney health and the formation of nephrons. So the big key here is that nephrons do not regenerate, and we have not figured out how to do that. So are nephrons formed after premature birth? This is a really important question that we're still finding new information about. So I think a while back in 2004, there was an autopsy study that was really nicely done on 56 premature infants who were born less than 1,000 grams. And in the study, they found that there was no evidence of new nephrons after 40 days of life, independent of birth gestational age. So the thinking at that time then was that babies who are born preterm may continue to form nephrons for about 6 to 7 weeks. So, take a 24-weeker, they might continue to form some nephrons up until about 30 weeks corrected. However, a recent updated study by Dr. Xu in 2023 also looked at 15 premature infants. 7 of them were 25 weeks who survived greater than 40 days compared to 8 control preterm babies. And she found that the timing of cessation was earlier in the postmenstrual age controls, but goes beyond 40 days and potentially up to 32 to 36 weeks. So this challenged the mantra from a couple decades ago that nephrogenesis probably stops at 40 days of life after preterm birth, and says that potentially they may continue to make nephrons up till the full 36 weeks like you do in utero. But I think there's still many questions left unanswered that we're trying to determine in future studies. But ultimately, I think we can likely say that premature infants stop forming nephrons earlier than postmenstrual age matched controls. So are these nephrons that are formed after premature birth normal? Sutherland et al. In 2011 did another autopsy study looking at 60 postmortem kidneys in premature babies versus controls. He found that 13% were morphologically abnormal glomeruli and they had a larger renal corpuscle as well as increased volume. In Dr. Shu's study that I just mentioned, she looked at 7 postmortem kidneys of 25-week premature babies, and she found distal tubular hypertrophy and hyperplasia. So my takeaway from here is that although they continue to form nephrons, the nephrons that are formed after premature birth are not normal. So this leads us to the Brenner hypothesis, which I think many of you will be familiar with, in that a congenital or acquired reduction in nephron number could explain an individual's susceptibility to hypertension and chronic kidney disease down the road. And the thought and thinking here is that nephrons can maintain a normal glomerular filtration rate, GFR, by enlarging or hyperfiltering. However, this hyperfiltering then leads to sodium retention, ultimately causing hypertension. It causes intraglomerular hypertension, which leads to proteinuria, and then leads to sclerosis that ends up in chronic kidney disease. So although the adaptive response is helpful in the short term, the hyperfiltration over a long period of time is harmful. So this figure from Dr. Carmody and Dr. Charlton that was published about a decade ago in Pediatrics really put this all together, and thinking that premature birth is a cause of reduced nephron number or oligonephropathy. This oligonephropathy over time causes hyperfiltration, leading to hypertension and proteinuria, ultimately leading to nephron loss and glomerular sclerosis, and then chronic kidney disease. So what evidence do we have from the literature about the rates of chronic kidney disease in former premature babies? Dr. Crump published about 5 years ago now a really nice epidemiologic study in one of the European countries where they followed their babies and found that all preterm babies around the age of 40, this is how far they had followed them, have about a 2 times hazard ratio of developing chronic kidney disease compared to term-born babies. And if you look at the extremely preterm population, babies that we know likely get the least amount of nephrons, their hazard ratio is 3. So this is how I now typically counsel my families and patients, is that any preterm baby has about 2 times the risk of developing chronic kidney disease, while the extremely preterm population likely has a 3 times increased risk of developing chronic kidney disease by the age of 40. And what I'm really concerned about is the 2-hit model. So we know that preterm birth already likely increases your risk of chronic kidney disease. But then when we think about the exposures that these babies have, both in the intrauterine environment, in the neonatal environment, that lead to things like acute kidney injury, and then you add on potential childhood associated factors like obesity, high salt diets, or hypertension, that the second hit then is really going to be what tips many of these babies and children over into developing chronic kidney disease and ultimately end-stage kidney disease. So my research team and me being a part of the Neonatal Kidney Collaborative are really focused on trying to keep the kidneys of neonates as healthy as possible during the NICU after preterm birth, and then ultimately determining what factors we can change to prevent the progression to chronic kidney disease. I always like to show this slide because I think it shows the histology of what acute kidney injury is like in the NICU. So the definition of acute kidney injury is an abrupt decline in renal function that results in a derangement of fluid balance, electrolytes, and waste products. So here on the right in figure C, you have a normal infant with normal histology, and this is a term infant. In the middle slide B, you see a preterm baby without acute kidney injury, and you can see already that they have larger glomeruli indicating hyperfiltration. And then in panel A, you can see this is a preterm baby who has developed acute kidney injury. You can see they have cystic dilation of Bowman's capsule, they have dilated tubules, and then they have that dark red infiltrate. So I really think, all we see typically clinically is a change in creatinine or urine output, and we're not really thinking histologically what's going on. And I think it's hard to see a lot of times with ultrasound as well, acute kidney injury, but I always think back to these histologic figures of what's going on. So what is acute kidney injury and how do we define it? The cutoffs have changed over time. So The historical definition of neonatal acute renal failure is what it historically was called, was any creatinine over 1.5 milligrams per deciliter. This has evolved over the last 20 years through multiple different definitions that have been adapted from the adult and pediatric literature. So P-rifle occurred in 2002, akin in 2004, and then ultimately around 2012, most in the neonatal community have adopted the modified KDIGO, or Kidney Diseases Improving Global Outcomes, modified neonatal definition. And the definition is such that a stage 1 acute kidney injury is in general a 0.3 milligram per deciliter increase in your serum creatinine over 48 hours, or a urine output less than 0.5 mLs per kilo per hour for 6 hours. A stage 2 injury is a doubling of your serum creatinine, or less than 0.5 mLs per kilo per hour for 12 hours. And a stage 3 injury is 3 times the baseline, or any absolute value above 2.5 milligrams per deciliter, and a urine output of 0.3 mLs per kilo per hour for 24 hours, or anuria for 12 hours. With the electronic medical record, it's relatively easy towards the end of a baby's hospital stay or during their hospital stay to graph their serum creatinine, and you can see these changes become really evident. So here with my arrows, I pointed out that this particular baby had 4 episodes of acute kidney injury, the first one occurring very soon after birth, going from 0.6 to 1, then another episode going from 0.7 to 1.2, so a stage 1 injury there and a stage 1 injury initially as well. This next one, the baseline likely is 0.7, and then the value goes up to 1.3, so almost a stage 2 injury. And then the final episode of AKI occurring when the baseline dropped down to 0.2 and the serum creatinine more than doubled to 0.5. I think we've yet to figure out if this increase in serum creatinine here that only went up to 0.5 is as bad as the stage 1 injury that went up to 1.3. So there are some things that we're still trying to figure out with this current AKI definition, but certainly, at least for this baby, the multiple episodes of AKI would make me very concerned. So approximately 10 years ago, there was a group that got together at the NIH to talk about neonatal acute kidney injury, which led to the formation of the Neonatal Kidney Collaborative, which did this groundbreaking study called AWAKEN. And in the AWAKEN study, they were able to figure out a lot about acute kidney injury, and I'll tell you everything that we've learned from the study, but the most important takeaway is what is the risk of AKI in babies in the NICU. And I like this figure because it breaks it down by gestational age. So if you just start up in the upper right-hand corner in the small pie graph up there, you can see that babies who are born less than 29 weeks and admitted to the NICU, about half of those babies have acute kidney injury. The relatively more healthy preterm population, 29 weeks to less than 36 weeks, only about 1 in 5 or 20% of those babies will develop acute kidney injury. And then the greater than 36-week population that's admitted to the NICU and on IV fluids for greater than 48 hours is a relatively more sick population, and about a third of those babies will develop acute kidney injury. So these are the numbers that I typically focus on and talk with my trainees and then my families about. The study, given the large number of babies that were included, over 2,000, ultimately showed that babies are not just dying with acute kidney injury, they're dying because of their acute kidney injury. So when looking at an adjusted odds ratio of mortality and length of stay, adjusting for a lot of significant factors, we found that the risk of mortality is 4.6 times, and that the length of stay is 8.8 times longer for babies who have acute kidney injury. So this was really important and has started to change the narrative about acute kidney injury. Because of the large number of babies and significant amount of data that was collected for this study, we were able to perform multiple secondary studies. So one of the first ones was looking at what are the early risk factors in the first week of life. We then looked at what the late risk factors are for acute kidney injury after the first week of life. We did a caffeine paper that I'll tell you more about. We looked at hypertension and found that the rates of hypertension are probably higher than what we previously estimated. and we're not very good at diagnosing it in the NICU. We found an independent association between kidney injury and IVH. We determined that still over 40% of babies with HIE are developing acute kidney injury. We did look at ways to optimize the definition for different gestational age cutoffs. We also found that chronic lung disease is more common in babies who have AKI, both greater than 32 weeks and less than 32 weeks. We've started to look more closely at fluid balance, both in the term and preterm population, to try and figure out what is the optimal amount of fluids we should be giving these babies to minimize their risk of BPD. We have also started to look at the PDA and how many babies have acute kidney injury with PDAs, which we know is a risk factor. We found that lower hemoglobins and anemia in the first week are associated with AKI, as well as albumin levels. So there's over 20 publications now from that single study, and they all are available on the Neonatal Kidney Collaborative website, which is babykidney.org. And those publications can all be found by year under the accomplishments tab. In some more recent data, the repaired study looked at acute kidney injury in LGANs. So this is actually a secondary study of the PEANUT study, which many of you are aware of and may have been involved in. This was 923 LGANs, where they used the modified neonatal KDIGO definition. However, they only used creatinine to stage and diagnose AKI. They did not use urine output. They determined that 38% of LGANs developed one episode of AKI during their hospitalization, and that approximately 20% had what we call severe AKI, which is a stage 2 or a stage 3 injury. And stage 3 AKI they found to be independently associated with death with a hazard ratio of 4.6. Here you can see the graph and a smoothed out over a 7-day window of what the serum creatinine is for the different weeks of gestational age. So you can see in general, 24-week babies have the highest compared to the 27-week babies. But you can see it takes close to 40 to 60 days for these babies to reach their nadir and baseline creatinine while they're in the NICU, starting off almost routinely above 0.8, but less than 1. And a really nice recent publication here in 2024 is an acute kidney injury in neonates meta-analysis. So this looked at studies over the past 20 years from 2004 to 2022. They included 200 studies from 45 different countries and ultimately had a group of 97,000 neonates that were either less than 28 days old or less than 44 weeks post-menstrual age. What they found was that any stage AKI occurred in 30% of babies, while severe AKI, stage 2 or stage 3 injury, occurred in 15% of babies. And this was very stable throughout all of the studies, independent of which country it was occurring in. When they looked at differences between preterm and term babies, they found that preterm babies have a slightly lower rate at 27%, while term babies are higher at 37%. And they found a consistent odds ratio for mortality of 3.4 for any episode of AKI, and then 6.7 for severe AKI. So we have now accumulated a significant amount of data with the AWAKEN study and this AKI meta-analysis, really showing that AKI is a significant morbidity in the NICU that increases babies' risk of mortality. One of the tables from this trial or from this study also showed the risk factors. So, and the risk factors pooled odds ratio as well. So the only one that wasn't significant and crossed 1 was actually nephrotoxic medications. But you can see there, other things to think about are PDA, necrotizing enterocolitis, perinatal asphyxia, and sepsis as the most common risk factors for acute kidney injury. All right, we're going to transition a little bit now into hypoxia and kidney hypoxia. So hypoxia is one of the common pathways that leads to neonatal acute kidney injury. And several different things lead to hypoxia in the NICU. So you can think about nephrotoxins causing hypoxia, hemodynamically significant PDAs causing hypoxia, hypotension, as well as anemia. And this common pathway then ultimately leads to acute kidney injury. Oxygen levels in the kidney are really variable. And I want to just spend a moment here looking at this figure where we can see the colors indicating the different partial pressures of oxygen that are typically present in the kidney. So you can see in the glomerulus, the highest partial pressure around 90. But then as you proceed down the proximal tubule, particularly down to the S3 segment, they have the lowest partial pressure of oxygen. So, and that creates the highest oxygen tension gradient, and really puts this segment of the nephron at high risk for injury when there are times of low oxygen delivery but high consumption. There's a few different ways that you can actually assess kidney oxygenation. One is through MRI and a technique called bold MRI. You can also look at blood flow with ultrasound. You can look at a measure in the urine called urinary oxygen tension. And the way that I've typically been assessing kidney oxygenation is through the use of NIRS monitoring or near infrared spectroscopy. So what is NIRS? NIRS monitoring is used to measure regional tissue oxygenation continuously. So similar to pulse oximetry, you have a sensor where the tip of the sensor has a light, and that light path goes in an arc down into the tissue and then is read by the detectors. It was designed primarily to measure brain oxygenation. So here you can see what one of the typical machines looks like, where you can read multiple different sites. And how it works is that this non-invasive sensor emits near-infrared light from the source to the detector at a wavelength of 700 to 850, and there's partial absorption of light by oxygenated and deoxygenated hemoglobin in the tissue microvasculature below. The actual formula that's displayed is a percentage, so it's oxyhemoglobin divided by oxyhemoglobin plus deoxyhemoglobin times 100%. Pulse oximetry works typically with a global estimate of the precapillary oxygen delivery to peripheral tissues, and the data comes from pulsatile arterial sources. What's important and different in NIRS and regional oxygenation is that it expresses the full tissue hemoglobin oxygenation without subtraction of non-pulsatile data. So it's looking at that full tissue segment, and individual tissues throughout the body are primarily a mix of about 20% arterial, 75% venous, and 5% capillary. So this number then provides us predominantly a post-capillary tissue oxygenation, or a surrogate estimate of what the local tissue oxygen utilization is. So when thinking about it as it relates to acute kidney injury, there's a time window when the kidney is becoming injured or is at risk of injury. And we have thought that potentially NIRS could be used as identifying a time frame when there's a window for early targeted intervention. So typically in kidney injury, the creatinine and urine output don't change until already damage or even cell death has occurred. But our hope is that with kidney oxygenation monitoring and what we're trying to study and prove is that we can use it at a time when the kidney is at increased risk of damage and potentially still reversible, where we could institute therapies to prevent progression to acute kidney injury, or at least decrease the length of injury or decrease the stage of injury. The way that I like to think about renal tissue oxygenation is in a supply and demand way. So when thinking about the supply of oxygen and blood flow to the kidney, we need to think about cardiac output and the potential low output states that our neonates experience, one of which is a hemodynamically significant PDA. We need to think about hemoglobin, and could there be acute blood loss if there's a sudden change in renal oxygenation, or does the baby have chronic anemia and require a blood transfusion? And then of course we have to think about, is the renal blood flow impeded with a thrombosis from something like an umbilical artery catheter? Thinking about demand is a little more complicated. You've got to think about what the potential renal perfusion pressure is, which determines the glomerular filtration rate and ultimately the tubular sodium reabsorption through the sodium-potassium ATPase pump, which determines primarily what the oxygen consumption in the kidney is. So I like to point out a couple different scenarios that you may see when monitoring renal oxygenation in the NICU. So let's say your value is higher than you expect. In this baby, they may have normal blood flow, but actually decreased demand. So if you expect the normal range of kidney oxygenation to be about 55 to 85, and you're seeing a value of 90 or 95, this is a baby that may have intrinsic kidney injury, like HIE, and the baby may not be extracting any oxygen, so you're seeing a higher than expected value. In contrast to that, if you're seeing a lower than expected value, so let's say you're seeing a value of 40%, this baby actually may have reduced supply, but normal oxygen extraction. So a more common scenario here would be a preterm baby with a hemodynamically significant PDA. So you can see both high and low values. Just to get a little bit into the logistics of renal NIRS monitoring in the NICU, the ideal placement for the renal sensor is on the posterior flank, below the last rib, and above the iliac crest. And when you palpate that location on most babies, even the smallest preterm babies, it's about the width of a NIRS sensor. And typically you're going to want to place that NIRS sensor with the light emitting tip close to the spine, but not overlying the spine. And then the remaining portion of the sensor is going to wrap around the flank. And in the smallest babies, sometimes even wraps all the way around the flank onto the anterior surface of the baby. I really think closely about skin protection. The last thing we want to do with our NIRS monitoring in the NICU is cause any skin injuries. So we've adopted an algorithm where we, in preterm babies who are less than 34 weeks, we use a piece of Mepitel underneath the sensor, and we actually move then the Mepitel with the sensor to the opposite kidney every 6 hours. So that way we minimize the amount of time that the baby is lying on the sensor, because there is a little piece of metal in the tip of the sensor that can result in bruising. And we found that by moving the probe every 6 hours, keeps the skin looking good and prevents any bruising or erythema. So now that I've introduced NIRS monitoring and the logistics of it, how often is it actually being used around the country? Last year, I did a survey of the members of the Children's Hospital Neonatal Consortium, so of the 45 sites. We had about 75% complete the survey. And what we found was that 77% of sites have NIRS monitoring available. It's only utilized clinically, though, at 50% of the sites. So most people are still using it for research purposes. As far as the type of NIRS monitors that people are using, the majority, 2/3, are using the Invos Medtronic monitor and sensor. And most centers have about 4 to 6 monitors to use for their NICU. When we looked at the indications for renal NIRS monitoring in this figure, the most common indications are ECMO and congenital heart disease. And then those are followed by the sickest babies, congenital diaphragmatic hernia and neonatal encephalopathy. And then other common scenarios would be sepsis, PDA, and preterm birth. What we asked people, what are limiting factors for use of NIRS monitoring in the NICU, and found that people said it's unclear how to utilize in clinical practice, and it's unclear what normal values are, and it's unclear how to interpret the data. A few people said there was lack of data showing improvement in care, and then some more logistical factors, the lack of machines, the size of the sensors compared to the baby, skin concerns, lack of NICU support, and then at the very one, some nursing mistrust of the technology. So I think we've now figured out that there's a lot of places using it, but there still are some limiting factors for the use of everybody adopting NIRS monitoring. So I've been trying to figure out what are normal renal NIRS values in the preterm population. We performed a collaboration with Dr. Chalk out at Stanford, where we combined some data sets that we both had on renal NIRS monitoring. And here in this graph on the left, you can see that we found that overall in our populations, the renal NIRS and renal oxygenation follows the same pattern. So typically decreases up till about 60 hours of life when it stabilizes from basically day 3 through day 7 then. This graph shows actually two different populations. The gray and black line is a more preterm population, or sorry, is a less preterm population. And then the pink with the red line is a more preterm population. So preterm, the more preterm you are, the lower your renal oxygenation. And you can see that the average value here is somewhere between about 50 and 75 during that first week of life. Previous studies have looked at the amount of variation from hour to hour that are present in both cerebral, renal, and splanchnic oxygenation. So Dr. Mintzer looked at 24 preterm neonates who had an average gestational age of 27 weeks. And in this graph here, you can see the cerebral is the darkest color, the renal is the light gray, and then the splanchnic is the dark gray. So there's the least amount of variation when determined by either 5, 15, 30, or 60-minute averages in cerebral oxygenation. There's a little bit more variability between 5 and 10%, basically about 10% per hour in renal oxygenation, and then significantly more variability in the splanchnic oxygenation when monitoring in babies. One important question that I think we've yet to solve that this group attempted to look at is, do all the machines and sensors give the same values? And from the study that they performed, I think we can very clearly say that it's unlikely that the machines and sensors of the different companies that have different technology and different algorithms are giving the same number. However, they were able to kind of correlate what the numbers are by machine, but this unfortunately is only for cerebral oxygenation, and we don't really know what the differences are machine to machine or sensor to sensor for renal oxygenation. So this is an area that I'm really interested in looking at and performing some head-to-head studies to really try and determine what are those differences when using other machines. In a study that I performed a couple of years ago, I attempted to determine if we could correlate oxygenation values from NIRS monitoring of the kidney to either blood gases obtained from the UVC, from the UAC, or from a capillary location, thinking that the most likely and strongest correlation would most likely be from the UVC, which typically is located just at the IVC-RA junction, with the renal vein emptying into the IVC relatively near to the UVC. However, in the study, we actually found the weakest correlation with the UVC to the renal oxygenation and the strongest correlation to the UAC oxygenation. So this is something that I plan to repeat in a larger observational study that I have going on now. And the reason that I did this is previous studies have correlated the cerebral oxygenation to SVC values of oxygenation, but nobody really in neonates has been able to correlate renal oxygenation to a true venous measure of oxygenation that we think it is measuring. So in my first pilot study of NIRS monitoring, we had 35 neonates that were born less than 32 weeks. Of those 35, only 3 babies had acute kidney injury. But all had significantly low kidney oxygenation, less than 50% prior to the time of their clinical AKI. So in this graph, I put the time of AKI in the middle of the graph at time 0 for each of the 3 babies. And you can see in the time leading up to the diagnosis of acute kidney injury by serum creatinine, they all had significantly low renal oxygenation, less than 50%, even up to 48 hours prior to the time of their acute kidney injury. And when we looked at the overall values during the first week of life in babies who developed acute kidney injury compared to those who did not, we found the average for the no AKI group to be 60%, but the average for the babies who did develop AKI to be 32.4%. In a subsequent study where we had combined our data with Dr. Chalk, we found that a decrease of 10 percentage points in your mean percent renal oxygenation was actually associated with a 1.7-fold increase in your AKI risk. So as your average renal oxygenation in the first week goes down, your risk of acute kidney injury goes significantly up. So we currently are using a guideline at our institution where we utilize renal oxygenation monitoring in preterm babies who are born less than 32 weeks or babies with HIE or congenital heart disease. If we have an abnormal renal oxygenation less than 50%, we first ask the team to evaluate the urine output and consider checking a serum creatinine. If those things are not abnormal, we'd like the team to think about anemia, as we know that anemia can significantly contribute to low renal oxygenation. Could the baby have a significant PDA that needs treatment, or is the baby hypotensive? And then if the NIRS values continues to remain low and all of those things have been ruled out, then we recommend evaluating for acute kidney injury and consulting nephrology if it is found, or looking at the use of nephrotoxic medications and considering a renal ultrasound. The other thing that we found is that some babies who develop adrenal insufficiency also actually have low renal oxygenation and acute kidney injury. So now I'm going to move on to some information about caffeine and acute kidney injury. I could talk about NIRS monitoring all day if you would like, so happy to answer any questions about that. So when we think about caffeine in the NICU, caffeine use in preterm babies has been associated with improvements in short-term kidney outcomes. So as I had mentioned before, as a part of the landmark AWAKEN study, we did a secondary evaluation and found that the number of babies that needed to be exposed to caffeine to prevent one case of early acute kidney injury in babies who were born less than 33 weeks was only 4.3 neonates, and for babies born less than 28 weeks gestation was 2.2 neonates. So really strong data there suggesting that caffeine may prevent acute kidney injury, or is at least associated with reduced rates of AKI. And the mechanism is likely through alpha-1 and alpha-2A adenosine receptors that results in decreased renal vasoconstriction and decreased tubuloglomerular feedback in response to hypoxia. We know that a cousin of caffeine, theophylline and aminophylline, has been recommended actually for use in babies who have HIE. So the KDIGO group, the Kidney Disease Improving Global Outcome group, actually recommends a single dose of theophylline within 6 hours of birth. And that data comes from a meta-analysis that had 6 trials, including 436 term neonates with birth asphyxia. And important to note that they were not cooled. And the pooled estimate from that meta-analysis showed that a 60% reduction in the incidence of AKI occurred in the babies with severe birth asphyxia who received theophylline. However, most centers and sites across the United States are not using this because it hasn't been proven or tested in babies who are being cooled. So there's currently a trial underway to look at this and collect PK data and look at safety. Dr. Chalk has published their use of aminophylline at Stanford, and they had 16 neonates where they did a PK pilot study, and they found that aminophylline use in neonates with HIE was associated with an increase in urine output and a decline in serum creatinine. So in my NIRS study, I decided to look and see how renal oxygenation changes in preterm babies after they receive just a standard daily dose of 8 milligrams per kilogram of caffeine. So we took a baseline average during the 6 hours leading up to their maintenance dose of caffeine and compared it at different time points to their hourly average after the dose of caffeine to see if renal oxygenation improved after caffeine administration. And what we found was, and we divided it by subgroups based on the baseline oxygenation, is that the babies who had the lowest renal oxygenation had the most significant improvements in their kidney oxygenation after their daily maintenance dose of caffeine. The group, however, that had normal oxygenation greater than 50% actually had a slight decrease in their kidney oxygenation. And although this was statistically significant, it's not clinically significant as it's just a small change in their oxygenation. So this got me thinking about, could caffeine actually result in less chronic kidney disease in this population? And there have been numerous studies in adults that have found an association between coffee drinking and decreased rates of CKD. And they think that mechanism is likely through antioxidative and anti-inflammatory effects, resulting in decreased endothelial dysfunction and atherosclerosis. So in this meta-analysis here, you can see the black diamond indicating decreased risk ratio for chronic kidney disease in those who drink coffee. So I wanted to look at this in preterm babies. So again, we utilized the peanut study data, which was the retrospective analysis of the double-masked clinical trial at 30 different US NICUs between 2013 and 2019. The babies were 24 to 27 weeks. They excluded conditions known to affect neurodevelopmental outcomes in that study. And as a part of the Neonatal Kidney Collaborative, we developed this group of studies called the ALMOND studies, cleverly, assessing the longitudinal micropreemie outcomes in neonates at risk for renal disease. Our primary exposure for this analysis was the timing of caffeine discontinuation as determined by the postmenstrual age at the last dose. So really looking at how long these babies stayed on caffeine. The limitation of this study was that we did not have the total caffeine dose available. We used a logistic regression with a general estimating equation to account for clustering by study site. And then we actually stratified the results by BPD status as it was found to be an effect modifier and retrospectively adjusted for it. So babies with BPD in general tend to stay on caffeine a little bit longer than those who do not have BPD. So we were able then to follow this group, or this group was actually followed as a part of that study out to 22 to 26 months. And we used 3 different outcomes: a GFR less than 90, an albumin creatinine ratio greater than 30, suggestive of proteinuria, and then blood pressure greater than the 90th percentile. Of the 940 babies that were enrolled in the study, 936 were randomized, and 780 lived until their 24-month follow-up, but only 598 babies returned at 2 years of age, and not every baby got every kidney metric measured. So the most frequent thing that was measured was blood pressure, so 469 of the 598. Then urine was the next highest, and then, as you would expect, the blood GFR measurement was only measured in about half of the babies that returned. There was about 25% babies in each of the gestational age categories. The overall average birth weight was 812 grams. And of NICU morbidities, about 65% of the group had BPD and 42% had a treated PDA. So looking at the 24-month kidney outcomes overall in this, you can see here that when we break down the gestational age in different bar graphs here, about 10 to 20% of the group at 2 years of age has a GFR less than 90. About 30% of the group has proteinuria at the age of 2 years of age. And then systolic and diastolic BPs greater than the 90th percentile range from 30 up to 50% of the group having high blood pressure at 2 years of age. So this was really concerning when we saw this, that these Algans may already be developing signs of chronic kidney disease by the age of 2 years. And then we looked at what the average postmenstrual age was at discontinuation of caffeine by the gestational age group. We found that in general, most people are stopping caffeine around 34 weeks, kind of regardless of the gestational age, but you can see the normal distribution of when caffeine is stopped. So ultimately what we found is that in babies, when we stratified by BPD, the babies who were on caffeine for the longest period of time had a slightly decreased risk of having GFR less than 90 in the no BPD group. But we did not find any differences in the BPD group for the length of caffeine use, and no differences in the no BPD group for proteinuria or blood pressure, but again, slightly decreased risk of developing a GFR less than 90 in the no BPD group when you use caffeine for a longer period of time. So ultimately, our conclusions from this study was that 2-year kidney outcomes of 24 to 27 week preterm neonates are very concerning for early progression to CKD. That longer duration of caffeine use in the NICU is associated with lower odds of low GFR in those without PD. And that given the high risk of CKD in this population, further studies are needed to understand this association as well as the effects of dosing, initiation, and duration of caffeine therapy on both short and long-term kidney outcomes. So before I end here in the next few minutes, I just want to talk a little bit about the follow-up of NICU graduates who are at high risk for CKD. The current recommendations from the American Academy of Pediatrics recommends that blood pressure screening occur at every health encounter in children younger than 3 years if they have a history of prematurity or other neonatal complications requiring intensive care, because these babies are at increased risk for hypertension. Unfortunately, that's not enough, and I don't think that this recommendation is being followed very frequently. And it's not enough because we know that children with moderate CKD are going to lose 1% of their kidney function each year, and even children with normal kidney function, but with some degree of kidney damage, have a 10 times higher risk of developing end-stage kidney disease before the age of 40. And we know that the rates of CKD in NICU graduates are going to increase over time, especially if they develop additional risk factors like hypertension, diabetes, obesity, and nephrotoxic medication use. I think the good news is we can potentially do something about it. So with appropriate screening, counseling, and treatment for CKD in premature neonates could have a significant health impact and also prevent CKD. It has been shown that interventions like controlling blood pressure, initiating ACE inhibitors, avoiding nephrotoxins like ibuprofen, and then monitoring blood pressure can support kidney health and prevent or delay the progression of CKD. We actually just recently, as a part of the Neonatal Kidney Collaborative, just this past month, published an article in the Journal of Perinatology where the title is Advocating for the Inclusion of Kidney Health Outcomes in Neonatal Research, a Best Practice Recommendation. So we detailed by the type of study that's being performed for any neonatal outcome, what kidney data should try to be collected so we can get more information on the true risk of CKD in these patients. So I hope that everybody can read that article and check that out, especially if you're planning to perform any major neonatal trials. As far as our research group, we are part of, or we're part of an R13 interdisciplinary expert conference to develop consensus follow-up screening guidelines. So we completed this at Indiana University with Michelle Starr leading the way in February. And we are currently have an article under review that should be published soon, in which we will provide recommendations for kidney follow-up in the first 2 years of life for preterm babies, babies who had acute kidney injury in the NICU, and then for babies with critical congenital heart disease. And then my goal right now is to perform a prospective randomized blinded placebo-controlled trial of additional caffeine bolus for renal hypoxia, and currently have an R01 that is under review. I could not do this work without my family, so my beautiful wife and then my 3 children. This is actually a picture from a couple of years ago now. Now my daughter's 3 years old. I had a great mentorship team. So back in fellowship, I worked with Dr. Jennifer Charlton, a pediatric nephrologist at UVA. She's brilliant. And then here at UW, Dr. Ryan McAdams, a neonatologist and our chief. And then Dr. Chalk at Stanford has been immensely helpful in establishing a NEERS guideline for our unit. And then Dr. Capitini has been helping me as part of my KL2. I have a great team of mentees in our research group that really keep me on my toes, and then have been really blessed to have some funding over the past couple of years to make this research possible. So with that, I'd love to open it up to questions, thoughts, or ideas that you guys have.
Super, thank you so much. If anybody's got a question, go ahead and put that in the chat or raise your hand and we can unmute you, or you unmute yourself and just ask. I noticed that you mentioned Dr. Michelle Starr. She's going to be talking with us in October on hypertension in neonates. So
Awesome.
We will meet more of the baby kidney crew.
Great.
So one question I'll kick us off that I have is about caffeine in particular. You had mentioned that all of us are pretty much stopping at about 34 weeks, regardless of gestational age. Is more better? Have a dosing preference or a duration?
Yeah, there was a couple presentations at PAS of people doing randomized trials of keeping babies on beyond 34 weeks up till discharge or even a month after discharge. And they had some really different or interesting outcomes that they showed in decreased rates of hypoxia, decreased rate of events. But they did find that growth was a little bit affected by the longer use of caffeine. So they didn't yet have brain outcomes or 2-year outcomes to make sure that that decrease in weight gain didn't affect neurodevelopmental outcomes. I would be really interested if we could look at the kidney outcomes as well and find out if a little bit longer caffeine might make a difference. I think even in my own practice, I've tended to leave it on a little bit longer till 34, 35 weeks, where when I think I first came out of fellowship, I was probably stopping it more 32, 33 weeks. But I think it does prevent some of that intermittent hypoxia that we see kind of in that late preterm gestational age before the babies go home. So we typically are using a maintenance dose of 10 per kilo, and I found that that works pretty well.
Perfect, thank you. I don't see anything in the chat so far, but is there anything else that maybe you can share with us in terms of maybe the most striking or telling secondary outcome from Awaken that we would want to pay attention to if we can't memorize the entire list?
Absolutely. I think the most interesting thing, in my opinion, was some of the crosstalk that occurs between the kidney and other organs. So the fact that babies who have acute kidney injury or have IVH have higher rates of the other one is really interesting to me. So how is the kidney talking to the brain? Why are those babies having increased rates of IVH? I think there is some really important connections there. So, we don't have a lot of things that can reduce the rates of IVH, but if we could reduce the rates of AKI and then secondarily improve brain outcomes, I think that would be awesome. So I think that's one really important area that we're going to continue to explore because I think that would make a huge difference in these babies' lives growing up. And I see a couple questions popping into the chat as well that I can try and address. So I see Daniel's got a question there. So silly question, there's never a silly question. Our unit weighs diapers on very low birth weight babies. However, more often than not, they're mixed with stool. Does your unit have a standard when calculating urine output or factoring out stools? We all start to worry when it's less than 2 mLs per kilo per hour mixed, but rarely put Foley's in. I think you've hit the nail on the head as far as one of the major problems we have in measuring urine output in babies is that we're not using Foley's and that we do have a lot of it mixed with stool. So I think as a part of the neonatal AKI definition, the urine output is the least studied area. There's been a couple of people that have looked at using a higher cutoff like 2 mLs per kilo per hour and found some really close correlations with important outcomes. So, I think we need to study that more. There's also people that are designing some new external devices for urine collection in preterm babies that we might be able to utilize that allows us to more accurately measure urine output without having a Foley in place. So I think in the next few years, we might have some cool new things that allow us to be better at detecting urine output. But yeah, we have the same issue as you do, Daniel. So another question, can you comment on the difference in using theophylline versus caffeine for renal protection? Yeah, I think it's really interesting. They're both methylxanthines, so they're very closely related. I personally feel like trying to study caffeine makes more sense as it's now used at 95% of centers. There's only a few holdouts kind of using theophylline yet, and just has a better safety profile. So personally, if I was studying it, I would like to try and utilize caffeine, but I think there's still a place for theophylline. So I guess that's my thoughts on caffeine versus theophylline. And Josh has a question. What clinical situations have you found NIRS to be helpful, or is it still largely investigational? That is a great question. So I actually point to one of the podcasts on the neonatal podcast where they had a cardiologist actually come on who said that he feels that since their unit started measuring renal oxygenation, they just have less babies have decompensate and have codes because they're changing care much earlier. So I don't know that it helps like singularly with one baby, but I just think overall, as a part of general care together, the more data points that we have, the better. And when renal perfusion changes, that's often a sign that your systemic perfusion is changing. So I think it helps in the sickest babies. Like, I don't think monitoring a 32-week baby who's on full feeds necessarily makes sense. But I think in that first week to 10 days of life in preterm babies, especially when you're coming off of IV fluids, transitioning to full feeds, the babies can get a little dehydrated, oftentimes a little adrenal insufficiency around that 7 to 10 days of life. As well, you can see a lot of acute kidney injury. So really that kind of actually a week to 2 weeks of life is where I found it to be pretty useful in the preterm population. Have you seen emesis with caffeine? Oh, that's a really interesting question. I actually have not seen much issues with emesis. I know there's some people that think that caffeine results in increased rates of reflux, but I personally can't say that I've seen a lot of that. And then our babies in the NICU are on caffeine most of the time. How does it correlate with your research? Yeah. So I'm actually going to try and keep all the babies are going to be on caffeine, and I'm going to give extra boluses of caffeine on top of their daily caffeine if they develop renal hypoxia. So I think, once in a while, many units will give a 10 or even a 20 per kilo bolus for babies who are having apnea, even when they're on caffeine, thinking you need to boost up their level. So part of my research I want to study, because nobody's actually looked at levels when people are doing that practice. So I want to study levels to make sure that's safe, but also at the same time looking at kidney oxygenation to see if we get improvement. So I'm not trying to take babies off caffeine. I'm just going to look to give them more of it and optimize the dose.
If there was something that we perhaps should remember before we discharge these moderate preterm or preterm babies, or at term equivalent age, what would you say we should absolutely do before they leave our care?
I think talking to the family and just making them aware that kidneys could be a potential issue for them in the future, and they should be aware that having their babies and kids have a blood pressure measured as they get older is important, and potentially avoiding things, especially for the most preterm babies, like ibuprofen and obesity is going to be really important for their long-term kidney health. So I just think putting that bug in the parents' ear before they go home, because they may not have heard it, right? We don't talk about the kidneys very frequently on rounds. We talk a lot about the lungs and the brain. But just at some point before they go home, taking a quick look, see if they've had kidney injury, look at their degree of prematurity, and just mention to the family that, now that they're leaving the NICU, some things that maybe we haven't focused on, like kidney health, might become important, and just letting them know that so they can be aware of it.
That's very helpful. I don't think I've ever asked a parent before they leave to think about obesity, Motrin, or making sure that they get serial blood pressure measurements at their PCP.
Yep, agreed. It is hard to do. It's hard to find that time to have that conversation when parents are, ready to get out. We're focused on just which medications to take. So maybe not on the day of discharge, maybe in the week leading up to discharge might be a good conversation.
As we're preparing, this is important. Okay, perfect. I think that's a great change of practice suggestion. I'll take that. Right. And with that, we're at time. I want to thank you so much for joining us. I really appreciate it. The work that you're doing, and we've got a lot of great presentations and things coming through. Again, we're going to have Michelle Starr come join us in October, and next month we have Dr. Rita Ryan. So please give a big hand of applause for Dr. Matthew Harer. Thank you.
Thank you so much. Appreciate it.
I couldn't even keep up with the Twitter posts because everything to say, so I just gave up. But we will post the recording very soon. Thank you all.
Awesome. Thanks. Have a
Bye,
great
everyone.
afternoon.
Have a great day.